Welcome to this Shockwave CPD evening. My name is Adam Naylor. I'm one of the directors for M20 Health. This evening we partnered with Physiquipe to basically present some CPD on our Shockwave, focus Shockwave system. So brief introduction, M20 Health is a private practice clinic. We're looking to link between elite professional sport and the standard private practice, so where we would provide technology-based treatments and performance support in terms of scientific testing as well as treatments. So the Shockwave event this evening is being led by Anders Broegaard. So I'd like to welcome Anders Broegaard to talk to you more about the effects of shockwave therapy. And from our perspective at M20 Health, we picked up the focus shockwave unit largely because of its reputable mechanisms and effectiveness on treating different acute and chronic injuries. And so far, over the past 6 months, we've had some fantastic effects on all types of upper and lower limb injuries. So without further ado, I'll pass you to Anders, and who can lead the evening from here.
Thank you.
Great stuff.
Thank you. Thank you to Adam and Ryan and Physiquipe for holding this little cozy workshop. And just to introduce myself, my name is Anders Broegaard, and I've been a chiropractor for 25 years now. Educated here in England, in Bournemouth. And since then, I've been in private practice in Denmark. And right now we practice in a multidisciplinary clinic consisting of 9 chiropractors and 4 physiotherapists. And we utilize X-ray, MR scans, high-end ultrasound scan and X-ray to help us diagnose these patient cases that we're gonna run through today. We have just moved to new facilities where we have some rehab opportunities, so we try to manage these patients in-house by working together to actually diagnose, treat and rehab our patients. I've been working with focus shockwaves for 20 years now. I was one of the, I think, first in Denmark who got a focus shockwave device, and I think I've been working with all the manufacturers' devices on the market so far. And I was introduced to this Piezowave technology with the older machines when they came out, and I've been working with this device here now, the Piezowave 2, since 2017, I think, when they came out first. And we now have 4 devices at the clinic, and we see about 250 patients a day, and with about 20 to 40 treatments are utilizing the focus shockwave therapy. So we're trying to really target that area, and we have a lot of patients, both normal, I see weekend warriors who actually got some musculoskeletal problems where we can utilize the problems, but we also see a lot of elite athletes where we try to help them with their problems. So I'm going to do a very brief introduction about the theory behind focus shockwave and its clinical implications. And then I'm going to go into the more experimental areas where you can use it too. And then I'm going to do a quick demonstration with this device, how we utilize it the best way to get the best clinical results, but also to make it as comfortable for the patients as possible. When you've been working with different devices, you find out that they work a little bit differently, and you have to adjust the treatment settings according to that. So I'll just go into that very specifically for this device here. This is now our focus treatment device of choice due to its high energy levels and low maintenance, and because it's so easy to work with. Less than 10 nanoseconds, and it's followed by a tensile amplitude. So we get 2 kinds of effects by applying these shock waves here, which I'll go into in a little while. Here we see a demonstration, or a graphical demonstration, of a shock wave, where we see the initial rise phase followed by this tensile negative phase. And what that means is that each shock wave that you deliver to the biological tissues are first influenced by the shock wave, which actually has a biological mechanical effect on the tissues. And it is followed immediately afterwards by this vacuum phenomenon caused by the tensile negative phase. So you are pushing the biological tissues very fast with the positive phase, and then you're creating a vacuum effect in the interstitial tissues afterwards. And we think those mechanical properties are actually causing these biological changes that we see in the biological tissues during and after shockwave therapy. If we compare to, let's say, radial pressure waves, we can see that they are much slower in the rise phase and negative phase, and the energy delivered by these radial pressure waves are not as high as with the focus shock waves. Also, all the literature shows that all the biological changes that we find in the tissues after we treat it with the focus shock waves are not reproducible with radial shock waves. So I'll focus on that. One advantage with the focus shock waves is that by using these gel pads supplied by the manufacturer, we can actually target tissues quite deep in the body. So say around the hip or shoulder, we can go down to 10 to 12 centimeters down to actually treat or target tissues in there. So we can target tissues within joint cavities and surrounding joint cavities quite deep in the body. As I told you before, there are several different technologies on the market for producing these focus shock waves. From the older equipment used the electrohydraulic principle to the more recent ones who are using electromagnetic. And then the most recent one is this piezoelectric device, where we have a bundle of ceramic plates lying within this parabolic headpiece. And when you actually shoot a lot of voltage through them, they expand and relax again. And by actually doing that, they create this focal zone of shock waves that you can target quite specifically the tissues or the target tissues that you want. So it's a few parameters that we have to work with, quite simple. First of all, the pressure field is described by the maximum pressure at the focal size of this cigar-shaped focal zone, which is actually the therapeutic zone that we target the tissues with. Then we have the energy, total energy in this zone here again, which is measured in millijoules per square millimeter. And then we have the total energy, which is equal to how many shots that we deliver to the patient at a given treatment. We normally, for musculoskeletal tissues, operate between energy between 0.05 to 0.3 millijoules. And these machines are able to deliver much more force, but not more is necessary to treat musculoskeletal tissue. And if you stay within these zones, you won't have any adverse effect at all. Normally, we use 2,000 to 3,000 shocks per treatment, depending on the size of anatomy that we want to affect, and the pain picture of the patient. So this is the device that we're going to work with today, and it's very simple. It starts up very quickly. There's no maintenance on it. The only thing that you have to figure out is which of the different therapeutic devices or headpieces that you want to use when you treat the patient. And then you just have to choose the energy levels and the amount of shocks that you want to deliver. All that can be altered while you actually are treating the patient. The good thing about this device here is that it has not only the normal cigar-shaped focal zone here, which we can actually adjust into the depth of the tissues that we want to treat, but we also have this linear device now, which creates a very large zone, treatment zone, focal zone. So you can actually cover a lot of anatomical space or tissue at the same time. That means that you can speed up treatment time, but you can also treat a lot of different tissues at the same time. And as you probably know as clinicians here, when we talk about a tendinopathy and look at a tendon which is degenerated or sick, we also see changes in the surrounding tissues. We see changes in the synovium, we see changes in the fat pads often, and we also see changes at the attachment sites of these anatomical structures. So being able to treat a large area, which is clinically relevant at the same time, makes really good sense when you work with these patients clinically. And that's the challenge we had beforehand when we only were working with a very small focal zone. We had to treat a very large area to cover the treatment. That could take a long time. So this new technology speeds up treatment. And that's a big issue when you have a patient that you have to finish, that it has to go quick. So with this device here, you can actually treat tissues up till 20 centimeters into the body. It has a gentle direct focusing, so you don't get any pain at the skin level. You only have pain at the target tissues. Some of the older devices and technologies, when you apply them to the patient, it'll give a lot of pain due to the shockwave distribution pattern. We don't experience that with this technology. We also have a very limited focal zone by using the Pinpoint device. So we can actually treat very, very exactly and target the anatomical structures that we want to target and avoid other structures like vessels and nerves, which are not so happy to be treated at high energy levels. So mostly when we go into this treatment form here, we nearly almost use diagnostic ultrasound to evaluate the tissues, the integrity of the tissues. If we are talking about tendons and ligaments, we want to see if there's partial ruptures, complete ruptures, if that's a contraindication to our treatment. And we would also like to see if there's any hyperemia or inflammatory changes going on, because that will also alter the total treatment protocol for this patient here again. So if you are able to ultrasound scan, I would definitely recommend that before you start treating. It'll also give you an indication of whereabouts in the tissues, how deep down and how widespread the changes are. So you can choose the right gel pad and the right headpiece to actually compress these details. It's quite easy to maneuver with, so you actually only have to choose what frequency you want to treat the patient with. And with frequency, I mean how many shots per second that you want to deliver, and then what energy level that you want to deliver. It also has a new technology built in, or a new program where you can actually, during treatment, you can set up the machine to alter the frequencies while you treat the patient, or alter the energy levels while treating the patients. So you don't get any adaptation of the tissues that you want to treat. So what you have to have in mind is that we are working with this focal zone here, and by using gel pads, we actually just disperse them further down into the tissues. So the focal zone is going to stay the same, but by using these gel pads, we just can increase the penetration depth of the device. So this device here is 20 centimeters in depth, and in width 4.5 centimeters, and it's about 4 to 5 millimeters broad. So we cover a large area, and this device is good at covering linear structures like ligaments and tendons, which are also linear structures. And then we have the other, here we see actually just a distribution of how you can apply it to a tennis elbow, where you can start with the attachment sites at the lateral epicondyle and move down into the tendon, and if applicable, moving down into the muscular-tendinous junction too, and sometimes go into the muscle too to treat trigger points there if you want to do that. So depending on the size of the focal zone, you have to take that into consideration when you use this linear device. If you move it 5 millimeters, not more, that would be the correct way to use this device. So I often use skin marking when I scan the patient first, so I can actually see what area I want to treat, and then I can plan my treatment protocol after that. Focus shockwaves were first in the 80s used to actually treat renal stones to avoid surgery, which is quite complicated doing that. And when they started treating up through the pelvic rim here, the renal stones, they saw that the reflected energy levels at much lower dose who actually hit the pelvic brim, they saw a buildup of cortical bone. So some German orthopedic surgeons thought, what can we do if with lower doses, if high doses can actually shatter calcifications, but lower doses can actually stimulate bone growth, where can we utilize that? And then they started doing a lot of experiments on fractures, pseudo fractures, non-union fractures, which didn't want to heal up even after surgical correction. And they found just after 1 or 2 treatments, there was a success rate of 80 to 90% of these fractures healing up at using these lower doses. And these doses are what we are utilizing now for musculoskeletal injuries. So a lot of studies have been done there, and a lot of university hospitals still have that as the first line of treatment instead of surgery to actually conservatively treat these injuries and bone lesions. We followed on for stress fractures, where we see the same success rate, 80 to 90% after 1 to 2 treatments. I treat a lot of stress fractures at the clinic, primarily in the lower extremity, tibia, fibia, calcaneus, metatarsal heads. We see massive callus formation after 2 weeks by just giving them 1 treatment, and we don't have to put them in boots or plaster them. They can walk around, just don't run and jump on it, and we see a healing rate within 4 weeks, so they can start up actually doing exercise again. So it's a very powerful tool to treat these bone lesions. A lot of studies have been done too on animal studies where we've been looking at fibrous and hyaline cartilage repair. And we actually see by severing a meniscus in a rat or a rabbit model, we can go in just giving 1 treatment of 800 shocks, and after 8 weeks, we see full repair of the meniscus. And if that's applicable to human tissue too, which much evidence points to, it actually opens up the treatment indications for many overuse injuries we see in practice here again. So we've done quite a few big studies on early osteoarthritis in the knee and hip, and the outcomes are looking very, very good. After 3 to 6 treatments, we see functional good outcomes and much lower pain levels. And right now, there's a few studies looking at the histological actually changes, and it seems like that if we still have some intact cartilage tissue, we see remodeling of that too in human tissue. And probably you treating a lot of knee injuries, ankle injuries, impingement injuries, where we still have intact cartilage, but where we see swelling and we see small fissures in the cartilage. These indications are what we're actually treating to with great success here. And still with a low dose as we use for the other treatments here. Most studies with focus shockwaves have been made on chronic tendinopathies, as you probably know, and bone lesions like non-union fractures and stress fractures. And we have a high degree of evidence together with rehab afterwards. It's always required. So focus shockwave does not stand alone. You have to utilize all your other capabilities and manual skills, and also the proper rehab protocols afterwards. When we look into the different papers, and I'm a clinician, not a researcher, I would like a protocol which is optional. But all these papers are not very good at describing their protocols. So they're simply not specific enough. So you have to do your own work and try it out. And because we've been so many at our clinic, we try to do different protocols during the years. And the protocol that I want to propose to you with this device is what we find is the most effective and takes the least time to actually apply to our patients. And it differs from manufacturer to manufacturer and from device to device. So we have different protocols for our older focused shockwave devices. The reason why we use this now is that it's so easy to work with and the treatment is so fast. So it's a great help in daily practice. But when we looked into these studies here again on the tendinopathy, it seems like 6 treatments is better than 3. So the more treatments actually seems to yield a better result. And now most protocols that we do include 6 treatments for chronic tendinopathies, cartilage lesions, and so forth. And when we go into the bony lesions, 1 or 2 treatments are sufficient. It also shows that with focused shockwaves has the fastest response in very vascular tissues. So like bony tissue, muscular tissue, synovium, you see immediate responses after a few treatments and sometimes during the first treatment too. Whereas the less vascularized tissues like tendons and ligaments, which respond slower, but they respond just as well, but it just takes longer time. If you want to go into a good overview of the research, International Journal of Surgery actually dedicated a whole issue with the newest research, and you can see on all the clinical implications what we have on research right now. So what we see the most in our clinic is these tendon and ligament lesions, and we have also started for quite some time to treat the acute stages, mainly because we can pain modulate these patients if we utilize the equipment in a certain way. And what our aim is actually to decrease the pain levels and increase the functionalness levels as fast as possible, so we can start rehab with proper proprioception and coordination for the patient, because we know the earlier we can do that without overloading the patient's structures, injured structures, the faster they respond and the better outcome we get to. So by also utilizing focused shockwaves for acute injuries, we can actually speed up recovery for about 50%. And that's not only ligament lesion, that's also fractures, fresh fractures in elite sports people here. We can actually choose to go in and do that and get them to heal up twice as fast, and even help them with the pain levels at the same time. So just mentioning that the advantages of using this linear device, which has a great focal zone, is that when you look at normal, let's say a chronic tendinopathy where we have a thickened Achilles tendon, compared to the normal one to the right, you can probably see that Kager's fat pad underlying has a different view or different appearance. One is very dark and the one is very white. And you can probably also see that the peritendon between the tendon and the fat pad is thickened. So we have a lot of structures being afflicted by actually a chronic tendinopathy. We see changes in the surrounding structures. And you probably see on the Doppler up here to the right, we have some hyperemia in the tendon. And that's actually coming from Kager's fat pad. We get ingrowth of a neurovascular bundle consisting of fragile, permeable arteries, which are not very healthy for the tendon, but also ingrowth of non-myelinated pain fibers. And in chronic conditions, these fibers stay in the tendon and interfere with the normal repair of the tendon. And we've seen with focused shockwaves that we actually apply that not only to the tendon, but also to the Kagel's fat pad, which is possible doing at the same time by doing the linear device. We see a retraction of these painful fibers. So we can actually, within a few weeks, we see that these painful fibers actually exit the tendon, so it becomes much less painful, and the patient is actually able to start rehab and strengthening exercise and stretching exercises at a proper level. A lot of studies have been done of that too, where we can actually see retraction and smaller sizes of these painful fibers in the tendon. We also see degenerate changes in tendons and ligaments where we get calcifications. And with focused shock waves at these moderate energy levels seems to be just as effective as surgery, just without any side effects at all. 80 to 90% success rate just after 3 treatments at 0.2, 0.3 millijoules per square millimeters energy levels. So surgery is not necessary there, as long as the calcifications are of moderate size, we can actually treat that too. So without going into the specifics of the biological mechanisms here again, we can see that when we apply focused shock waves, we get depolarization of the cell membranes, and we see a stimulation of a lot of different biological signal pathways, which are actually causing repair and remodeling of the tissues. We also see stimulation of microcirculation and angiogenesis. So we see ingrowth of new small capillaries where they haven't been before. We see modulation of a lot of these pain substances which modulate pain patterns in the tissues, like substance P. After a few treatments, we actually see a normal levels of these substances in the tissues, which are where we are able to decrease pain in the tissues within 2 or 3 or 4 treatments. We also see anti-inflammatory and antibacterial effect by using focused shock waves. And then we see one of the main reasons why we see this remodeling is like a stimulation of growth factors and stem cells immediately after treatment. The newest pain research on focused shock waves actually shows that it's not only the peripheral tissues that we affect, it's also the number of neurons and neurotransmitter levels at spinal levels, which are affected after a few treatments. And we also see modulation of higher cortical centers, both in the brainstem and in the cortex, just after a few treatments. So we get a whole pain modulation pathway activated by actually utilizing these focused shock waves, because they have such a high energy on the biological tissues. So by using these devices at the energy levels that I just mentioned, it's a non-invasive technique. We don't see any side effects as long as you stay away from a few tissues. Like, we don't use shock waves over air-filled cavities. We don't know what it might affect if we go over the lungs. We don't use focused shock waves near the fetus of pregnant women. We stay away from tumors where we don't know which effect it might have. We also stay away from large vessels if there might be some calcifications in them. We don't know what effect it can have. None have been reported in the literature. So it's just because we don't know exactly how it could affect people. It's also been a contraindication to treat spinal tissue. But it seems that with low doses, we actually can cause regeneration both of neurons and of peripheral nerves and of spinal nerve tissue too. So a lot of studies have been coming out, and now we actually do transcranial shockwave therapy for dementia and Alzheimer's. And preliminary studies show actually 20 to 30% improvement in cognitive behavior. So you can actually regenerate neurons and nervous tissue by using lower amounts of energy. So new studies show we can speed up not only recovery for chronic condition, but also acute conditions, which actually puts it into a whole new ball game for acute musculoskeletal injuries. And we can also see if we apply these devices properly and use the proper protocol, we can desensitize the patient within a few treatments and accelerate our rehabilitation scheme too. And we can also treat deep structures around the hip, iliopsoas, labrum structures, cartilage structures within the joint, if we want to do that, and want to target that too. So, as you can see here, tendon, ligaments, bone, cartilage, muscle, synovial tissue, fibrous tissue. We can address all these different kinds of injuries because focus shockwaves has the same working mechanism on the human tissues that way. We can also augment other, like say, injectional therapies, like stem cell injections. One of the reasons is why they not seem to work that good in the literature is that if you apply them to areas where you can't mobilize the area at the same time, then you can't activate these stem cells. So we have made 8 or 10 studies where we actually done PRP injections followed by focus shockwave, and you see immediately an activation of the stem cells where they were injected. And compared to not using the focus shockwaves, it's shown a 70 to 80% better clinical result if you actually do that. After surgery, where you have metal implant screws, like say an ACL rupture, where you actually put in a new tendon and you fix it with the screw to the tibial plateau and the femur. About 10% of these surgical cases, you get loosening of the screw and loosening of the ligament in there. If you follow it up by one treatment of focus shockwave just after surgery, you see a massive callus formation around the surgical implants, so you don't get into that problem where the screws are loosening up again. So you can use it as an adjunct to many other surgical or injectional therapies too, where it's indicated. So we treated several professional football players with massive ligamentous injuries around the ankle, which weren't surgically candidates, and we treated them with the PRP injections and followed by one treatment of focus shockwaves, and they really responded very, very good. And then again, no side effects. The worst thing you can do is get no effects, but you don't get any worsening of the conditions. So as long as you stay within these parameters here again, you can actually only aim to help the patient here again. I was ordered by my wife this autumn here to do some house cleaning, and we had some spider's web up in the ceiling, and I had to balance on a chair with a vacuum cleaner to get it down, and I lost my balance and fell down barefooted on my heel and had a fracture of my calcaneus. So never do housework in these circumstances here again. I got to the hospital and knew exactly what was happened to me, and I got a CT scan, and I had a fresh fracture without any displacement. I went straight out to the clinic and treated myself with shockwaves. I had 3 treatments, and within 2 weeks I had a full healing of the calcaneus with full callus formation around my calcaneus. So after 3 weeks I was back at work again, and the surgeons told me first I'd had to stay in my plaster for 12 weeks. So even with a man in my high age, I have the ability to actually heal up by using focus shockwaves on fresh fractures like that. They're doing a big research in a German hospital, University Hospital now, where they're actually taking sports people in from skiing accidents and giving them a focus shockwave straight away with minimal plastering around these areas here again. And the preliminary results are very, very encouraging, where they can actually speed up recovery with 50 to 70% in time span. So in my work, we only seen the tip of the iceberg about what this technology actually can help us with. And as long as we don't get any adverse effects, it's just straight to dive into and use in the daily practice here. Any questions so far?
You mentioned that it can be used for stress fractures.
Yes.
You said that it can double the speed of stress fractures are healed.
Yeah.
How many treatments would you normally advise for a stress fracture?
I do 2 treatments, 1 week apart. Normally I try to evaluate them. So most of them I see have actually had the pain for some time, because the stress fracture is not an acute problem. Most runners, for example, they feel something happening when they're out running, and they can run, but they can walk still, because the stress fracture is not totally acute and not limiting their daily activities that way here again. So most of them come in to me after 4 to 6 weeks where it hasn't gone away. I do typically at the superficial bony structures, you can do an ultrasound scan and evaluate the cortex even better. And I do an X-ray or CT scan on them too. And if there's no cortical callus formation, it's an indication for me that I can actually go in and do something here. Because after 4 to 6 weeks, if there's no cortical response for stress fracture, it's in my way an indication to actually start treatment. Normally we say it has to have been there for 3 to 6 months, but if there's nothing happening after 4 to 6 weeks, it's not going to happen either in my clinical experience within the next month. So I might as well start treatment straight away. And after 1 week, you see callus formation. After 2 weeks, you see massive callus formation around this area. And they all heal up as long as you control the activity levels here again. And they can walk around in normal shoes and things like that here too. And the faster and the fresher the tissues are, the better they respond in my way too. If you had a non-union or stress fracture and been running around with that for several years, you get an amorphic tissue, like some of the bony structures actually degenerate so much that you can initiate healing in the tissues again. So if you wait too long, you might have missed the window of opportunity too. It's painful. So we have some pain plasters that we put on, so the patient has to put on 2 hours before, and still then it's painful. But if you modulate the treatment and increase the energy level slowly, it is tolerable by the patient. And if they know they just have to have 2 treatments, they're quite motivated if they can come out running again after 4 weeks.
Got a couple of questions from online, if that's all right.
Let's take them now.
So from Simon Edwards, he's currently got a professional rugby player with a long-standing Achilles enthesopathy.
Yeah.
It's a mouthful. It's been reviewed by a consultant surgeon who does use Shockwave, but is uncertain whether he should use it on that indication and concerned it will be too painful. Any thoughts?
I imagine when we're talking about enthesopathy, we're talking about insertional tendinopathy, probably with some spur formation or Haglund's heel or something like that.
I assume so,
yeah. They're more resistant and resilient to treatment if you go into the insertional tendinopathies, which we were covering earlier today. And often you have to increase the energy levels, the dose energy, the frequencies, the amount of shots that you deliver at the treatment. So I might do 4,000 shocks because we see a slower response at the tendinous attachments around the bony structures. They're much more fragile. There's less blood supply to these areas. So I might have to treat, just the insertional areas with 2,000 to 3,000 shots, and then treat the tendon afterwards, the proximal tendon, just attaching to it. So they're much more resilient. But if you increase the dosage, which we've done, we get great results too. And it's painful, yes, but it's not unbearable as long as you slowly increase the energy levels during treatment. And one of the tricks here is that you use the protocol I'm just going to show here, because if you can desensitize the tissues, then the patient can tolerate higher doses of treating them. And there's a trick to doing that, which I will show you here. And it's very, very simple. So you just have to, when you apply the therapeutic source, you have to stay at the same area until the patient tells you they're desensitized. Then you can move it on to another area at the insertion level, and you do that at the whole insertion, and then you can increase the energy doses without actually causing too much pain. But you cannot just move the probe around. You will actually stimulate and even exacerbate the pain response from the patient. You have to take one area at a time with the insertional tendinopathies. Then you can actually achieve the the required energy levels that you want to treat them on.
So onto that, do you think so? They're using radial from the sounds of it. That might be too uncomfortable. With your experience with focus, do you think it would be more comfortable, less comfortable, or is it just going to be just as gnarly?
It's a different kind of pain, so it's,
yeah,
the discomfort is the same.
yeah.
So, but you just have to dose it in another way.
No, it's just one more of the question. Is can a patient continue with the working activities that may aggravate their conditions? So can they continue as normal after a shockwave treatment?
You have to manage your patients. So don't reproduce known symptoms. Don't exacerbate the pain. You're just going to prolong the treatment. You have to respect that the tissues have to heal up. So you don't want to provoke the known pain while you're actually doing the treatment. So with all our patients with ligamentous or tendon lesions, we tell them to don't pain provocate your site of injury for the next 3 to 4 weeks. So it takes at least 3 to 4 weeks before you actually have enough healing and sustainability in the tissues before you can start loading them and play a little bit with symptoms again. But if you don't follow that advice, you'll just prolong the treatments. It'll take more treatments, it'll take longer time to treat the patients. And sometimes it's better just to take in 3 or 4 weeks instead of 8 to 12 weeks. So you really have to motivate the patient and be clear spoken about what they can expect if they don't listen to what you say. But then again, we have many top tennis players, soccer players, handball players, and they have just to be in this season. So I can hold the pain levels down and I can increase the functional levels, but I won't be able to manage them totally. I can just keep them in the game, and that's the choice they take. So you have to evaluate each patient. Where are they? What's the expectations? What are the demands and so forth, and manage them that way. So you have to, you have to clear your expectations with the patient here.
Sorry, just following up from what I said before about stress fractures. So you said you'd wait 4 to 6 weeks before doing those 2 treatments rather than doing those treatments right at the start.
Yeah, but normally patients don't come to me at early stage. They hope it goes away. I normally see most of my patients after 3, 4, 5, 6 weeks earliest with stress fractures. With acute fractures, larger fractures, I see them, of course, much earlier here again. And with a very acute and large stress fracture, I can see them earlier too. But I would like to start treatment as fast as possible. It can only accelerate their healing. So, and if the patient would like me to do that, I'm there for them. It only makes sense for me. And when you've been scanning and CT scanning and X-raying these injuries for such a long time, you see that stress fractures don't initiate healing by themselves. And if they don't, and that should be done within the first 2 or 3 weeks. That's like bone. That's how bone heals. So if you see a delayed healing, you might as well start treatment straight away, as fast as you can. Should we do a practical demonstration? Yes. So we'll just start using this device here, and just to prepare the system here, we'll start using the linear device. So I just plug it in here, turn on the machine, and we have a small injury here. Adam, he's just been painting his house this weekend, and he has a painful lateral epicondyle. So he has an acute injury. So So we're going to try and treat that. I just ultrasound scanned Adam, and I can do that again here. So should we take the Piezowave so you can lie down while I do it? And also, always when you use focus shockwaves, have the patient lying down. It's a painful procedure, and sometimes you can get this adrenaline kick, so they actually faint during treatment if they sit up. But if they lie down, you don't get into that problem. So it's your left, okay. Yeah, so if you just lie here. Just lie on your back for me. And with all structures that you want to treat, especially the flexible structures like tendon and ligaments, you want to place the tendon or the ligament in as a superficial position as possible, and with a light stretch on it, so you can actually expose most of the tendon tissue. And you have to take that into consideration too. I'm just gonna use this chair here. And also because these devices here, they work with, for the shockwaves to actually enter the body, you need coupling media, which is gel, and a gel pad on gel and on skin is very slippery. So having the patient lying down, you'll be able to control the area that you actually treat. So we'll just start scanning here, and I would like you to put your hand in here. So we're just going to expose the tendon here. So we go in on lateral epicondyle here. So we try to look at the structures here. So we're looking into the tendon tissue. So cursor is, what's the cursor here? It's this one here. So what we see here, where's the cursor here? It's, I just have to, that's the one here, okay. So here, we have the lateral epicondyle. This tissue coming in here, here we see the joint space between the humerus and the radius. And we see the tendon coming in here, attaching up here at the lateral epicondyle. And we see a little tiny calcification, spur formation up here, very, very tiny. We look for a good signal of the tendon here. There shouldn't be any dark areas. And what I found just before here was a quite healthy tendon. So it hasn't become very inflamed or anything like that. We just put the Doppler on to see if there's any hyperemia, inflammation in the tissues. And it seems quite quiet to me. So we don't have any structural changes in the tendon right now. So this is an acute overuse injury, painful by palpation, and when he uses the arm. So I would go straight in and using this linear device. So we come over here. And as you probably saw, you can actually measure the levels where the tissues are lying by using the ultrasound scanner, and the tendon is actually about 5 millimeters down, the center of the tendon from the skin level. So I'll like to use a 5 millimeter gel pad here. So we'll actually center our focal zone, treatment zone, 5 millimeters below skin level, and that's exactly where I want to be. So you put this gel pad on and pressure all the air bubbles out, so you actually get full dosage when you turn on the machine. We take a little bit of gel on here. And then we can play with these two different like parameters here. We can play with the frequency. And I have a tendency to always lie around a frequency of 8. In my experience, that's what the patients actually can tolerate the most. Lower frequencies don't seem to work that well, and higher frequencies can be a bit uncomfortable with this device here. So that's what I use the most. And I start with a low dose just to target the tissues and see where the pain is actually where the pain area is. And by doing that, you have to communicate with the patient. So you want to elicit the known pain that the patient actually experiences. So I would recommend you to start like at the muscular level, muscular tendinous junction, and work up towards your attachment site, because that's always always the most tender point here. So you want to start out softly. So palpate the lateral condyle here. So I start down here at the muscular level, and I work my way up. And Adam, do you feel anything here? Yes, I'm going to move all the way up. And we over the tendon now. Any pain here? And up at the attachment side here, at the lateral condyle, pain here. And if I go just behind that, pain there too? Okay. So we actually have an area about 1 centimeter that I have to treat, I can see, from the attachment site, from the lateral condyle down to the muscular tendinous junction. And the width of this therapeutics target zone is about 4 millimeters. So if I just have 3 spaces to put it on and move it on 0.5 centimeter, I'll be covering the whole area. So I always start at the most distant point at the tendon just to pain modulate the patient. And I keep the device on until the patient says that the pain is subsiding a little bit. And was that the pain that you experienced too when you use your arm? Yep. Oh, yeah. Okay. So I'm going to come up here again. And I'm just going to increase the levels a little bit here. And we come in here. You tell me when you start feeling anything. Right there. Yeah. Okay, I'm just going to hold it on, and I'm going to look at the number of shots. So I'm at 400 now. And normally you have to hold it here 300 or 400 shots before the pain modulation starts. So I make sure that I'm on the same spot. And you tell me when the pain subsides a little bit. Already a little bit less. A little less. Yeah. And with tendon tissues, I always give it a minimum of 300 to 400 shots before I move it on. And right here, I would like to give it at least 500 to 600 shots. Tell me when it's decreasing even more. So we've been nearly for 300 shots now. So I try to place my hands on the patient's arm so I don't move the device around, and start stimulating surrounding tissues and structures. Now, from 0 till 10, where 10 is the most unbearable pain, where would you say you are on the scale? 7. Started at 7. So now we've been here for 600 shots. I'm going to move it a little bit up, about 0.5 centimeter, and that's just going to increase the pain a little bit. Yeah. You tell me when it's going to subside again. Okay. So right now, I'm not only treating the tendon, I'm also treating the surrounding tissues, like the collateral ligament, the joint capsule, and over the tissue within the joint, which might be affected too from this overuse injury. And we hold on here again. Down a bit now. So by holding it the same spot, you're actually causing some form of depletion of neurotransmitter substance and pain mediators in the area. And when you treat that, you actually see that it's going to cause the modulation of the future levels of these neurotransmitters and pain substances in the tissues. Now, I'm going to move it a little bit up now again. That's probably the most painful spot. We're right on the lateral epicondyle now, the bony attachments. That's the most painful area. Now that's where actually where most of the pain is. So that's where we're going to target the treatment and maybe give 500 to 1,000 shots here. That's where I got most pain. Yeah. You tell me when it starts subsiding. It might take a little bit of long time here. So you have to be patient and just hold the device on the same spot. So we're actually seeing some pain modulation already. So what we want to do with this acute injury is to actually pain modulate it to create the best circumstances for this little overuse injury to heal up again, so it doesn't go into a chronic irritation. And now we've given it about 2,000 shocks. So I'll conclude the treatment there. If I go down into the tissues further down now here, how does it feel here? Okay, fine. Fine. So, and if I just come up and scan here, painful here. Yeah, so it's just the end here, at the end attachment here. But patient also is already pain modulated, and afterwards they won't be able to feel that much pain. They'll actually be able to use their hand without any pain patterns. The pain will return tomorrow. So it's not over like that. But if you apply that technique for each treatment, you can use a higher dose, and the pain levels will be decreasing. And after typically 4 or 5 treatments, I can use a very high dose, and the patient will be able probably to start some form of rehab, isometric stretches and things like that, where you don't load it too much. At some reason, medial and lateral epicondylitis are very, very painful, and they often require a larger dose. So even though I only use 2,000 shocks here, I would probably just give it some more at the bony attachment, 1,000 shots more. And I do that with all insertional tendinopathies. They just require some more energy levels. And because research which have been done on these conditions always have been within the parameters of 2,000 to 3,000 shocks, they haven't responded that well in the literature. But if you increase the dose at the bony attachments, you'll get just as good clinical results in my experience. It's the same with Achilles tendinopathies, insertional tendinopathies. You have to increase it to a double dose down at the bony attachments, and use exactly the same procedure where you hold the device at the same spot until the pain subsides. I don't know why, but that seems to work.
Do you ever see overdose where somebody does it too much too quickly and it irritates the tendon?
I see. If you start, if you use a dose and you do like this, and you move the device all the time on very acute conditions or even chronic conditions, you'll just exacerbate the pain. And the patient will feel it very, very comfortable because you stimulate a new pain point every time. It's just like somebody sticking with your needle at a different place. It's not very nice, but if you have it the same pressure at the same spot, you can better tolerate it. And we don't know if it's the peripheral pain modulation or maybe at the spinal level or higher cortical level that shoots in there. We don't know. But what studies have shown that if you actually anesthetize people by using shockwaves so they don't feel anything, they don't get any pain modulation at all. So the pain perception is very important that you have that somehow. That's how how you actually cheat the nervous system somehow. So you just have to keep it within limits where the patient can actually tolerate it. But then again, if you've had a problem for a long time and nobody's been able to fix it, and you put this device on and you can reproduce the patient's symptoms exactly, and just after the treatment, they can actually stand up and they can press on the tissues and use their arm, even though it's not permanent. That is a great motivational thing to do for the patient, and you will find it much easier to actually motivate the patient to follow your treatment plan and follow your advice. And then again, sometimes when we do a high-end ultrasound or an MRI scan and we simply can't see which tissue is actually causing the problems, then I can use this device or the Pinpoint device, and I can target individual anatomical structures. And if that reproduces the patient's pain, then I know exactly what I have to target both treatment-wise and rehabilitation-wise too. So I use it just as much as a diagnostic tool. And it's great actually to be able to crawl inside the joint and actually targeting special anatomical structures to see which is actually responsible for the patient's pain. You can only do that in a much more broader aspect where you can actually inject some steroid into a large area, but you still don't know which structures within that area are causing the problem. And that's why we have all this polemic about surgery for knee problems and menisc problems. Are we actually doing the patients any good? Or are we just taking a shotgun and try to eliminate all the possibilities? So this is a more intelligent way actually to find out what's going on within the patient's joints or tissues. And sometimes you'll be amazed about what structure is actually causing the problem. You wouldn't have been able to examine it or see it on any scans or MRI scans, but you will be able to pinpoint it with this device here. Makes sense, doesn't it?
How do you determine, do you have protocols or specific treatment settings, or are you personalizing things for each patient? Like, how do you decide?
You always have to take the individual patient into consideration, because patients have different pain tolerances, and even though you have an acute lesion or a chronic lesion, they might respond totally differently. So you have to take all the examination work into the aspect with it. Of course, if you're talking about limited lesions like a tendinopathy, we have the same rules applying. When we're talking about cartilage lesions, menisc lesions, it's a little bit more complicated. You have to take into consideration what's actually innervating these tissues and causing the pain problems. Like we know in the knee, we have no innervation of the cartilage or the inner parts of the meniscus. We only have innervation of the outer parts of the meniscus and the cartilage actually. So you can have massive lesions which are not causing any functional problems to these tissues, but it's mainly just an attachment site of the meniscal ligamentous fibers which are causing all the pain. If you target that with the focus shock wave and pain modulate that, you'll get them free of pain, even though they have bucket hand lesions and lots of other lesions in the meniscus and lesions to the cartilage too. So it's not where the pain is coming from. So you have to take function into aspect and the pain patterns into aspect. So if I can, even though we have a degenerative knee, if I can create normal function and pain-free, I don't care that much about the structural damage within there. That's not what the patient is complaining about. We just want to secure that we take away the pain-producing aspects of this injury, and we want to rehab, increase the strength and proprioception around the knee too. So don't think so much structures, think more about pain physiology and functionality. That makes sense in my work here, because I see a lot of patients with a lot of arthritis and a lot of injuries, but they function perfectly and they have no pain. And that's a big advantage with the focus shock wave, is that you can play with these pain patterns and actually eliminate them. So that's really good. Whereas you can, often the only other alternative is corticosteroids, which is not recommendable for long-term relief in nearly all studies when we talk about these lesions here again. And it has no side effects. Think about that.
Before we take some questions that have been submitted online, has anybody in the room got any questions or comments at all? Chirp in any time. We've got the microphone, so we can go on. Anna's for you, question online talked about stress fractures.
Yeah.
What settings, I assume, as in frequency and energy levels, are you looking at? What's the kind of range that you would look at to treat a stress fracture?
I know it because stress fractures can be quite painful. I normally use a frequency of 8 with nearly all my musculoskeletal injuries. It just works best for me and the patients. They respond the best by using that frequency. And I start out by using a low energy level and increase it slowly to start with. So having a stress fracture, you know exactly where you have to treat the patient. So you can just put your scanner on or take an x-ray and you can actually measure out the area you want to treat. So I start with a very low dose, 0.05 millijoules, go up to 0.1. And that's maybe the maximum for the first treatment. And they seem to respond quite well to that. Second treatment, I can maybe go up to 0.2, 0.3 millijoules. And it has a great effect. The older studies, they use much higher doses, but that's not necessary at all. Newer research shows, and also my clinical experience, you don't need any more. And that's easily acceptable by the patient. It hurts, but you only have to do it twice.
Another question online. Can you treat a patient who's in remission with blood cancer? Not had that question before.
You have to take in the total state of the person's health. So if they are in stable condition and you're not targeting the spleen or bone marrow or anything like that, I would say it would be quite safe, yeah. The reason why we have this condition like cancer as a contraindication is that we don't know how it works. But we have 4 or 5 good quality studies on cancer of the bladder and prostate. And when they do histological studies on these people, it actually has shown to actually decrease their cancer levels and cancer productions of these enzymes down there. So it's not only antibacterial and anti-inflammatory, it also seems in these studies that it actually has a protective effect. But we don't know about all the other cancer conditions. So I would definitely talk to the oncologist who actually supervises the treatment before you start it out. But this condition I wouldn't see as a total contraindication.
Excitingly, we've got some international guests online, one from Bulgaria.
Yeah.
How is focused shockwave applied in cases of partial rupture?
That's where you have to really examine the ruptures properly. So we do, if you have more than, let's say, 50% rupture of the tendon, and if you have retraction of the tendon too, and have a retraction more than 5 millimeters, then the success rate is very low. So those kind of patients, depending on their age, I might refer to the orthopedic surgeon straight away instead. So when you're dealing with structures and where you have partial ruptures, you have to examine the tendon dynamically to see how stable is the anatomical structure. Is it too viable? Then your success rate decreases a lot. Separation of the anatomical structures of more than 5 millimeters decreases your success rate quite drastically. So so you have to properly, if they have a partial rupture with some retraction, you have to immobilize them in a position where you actually cause acquisition of the tendon structures, for example, and then you can try it out. Depending on the age, that's how sport specific they are, because then surgery could be a proper alternative instead.
As an addition to that, when you've got ruptures, is there a risk, or partial ruptures, is there a risk of when you apply Shockwave that you could create a full rupture? Is there any evidence of that?
No, we have 2 or 3 adverse effects after treating Achilles tendinopathies, where they had partial ruptures, and they were older men, and some of them experienced a complete rupture. But just like if we actually, it's a very normal complication for doing corticosteroid injection in Achilles tendinopathies. We see a high percentage of those patients who actually completely rupture the Achilles tendons. But there's a quite consensus now. It's not the treatment that we deliver. It's because we actually decrease their pain levels quite fast, and then they think they can start running again too early. So you have to manage these patients. So with these doses, I don't think you can provoke a rupture. You can only initiate a repair process. But if you pain modulate them and don't regulate their activities properly, and they think they can jump down the stairs and go out and run 5 kilometers, they probably are in a risk of totally rupturing that tendon. But nothing points to the contrary.
On the point of with steroids, it's a question that we get a lot as well, is how long after a steroid injection do you have to wait until you do Shockwave treatment, or can you do them together?
I'd say if you opt for a steroid injection, you have to give it a chance to work. And you don't have to actually, you shouldn't start Shockwave treatment on a patient which just received that. I always wait at least 2 weeks, because in my work, when we actually do the studies which have been done, they don't see any remnant steroids in the tissues after 2 weeks after an injection therapy. It's used up by the tissues. And what you want to do with a steroid injection, which can be very indicated if you have an acute bursitis, I'd like to do some inspiration and a little bit of corticosteroid in it, leave it alone for 2 to 3 weeks, and evaluate the tissues again. And if it's necessary to do some focus shockwaves, then do it at that time. But give it time to work. And at least 2 weeks I would recommend before you start using focus shockwaves.
Couple more questions online. And obviously we can see if there's anything else in the room. Otherwise we'll then start to wrap up. So has it been used in the spine at all? And what indications in and around the spine could you use focus shockwave for?
Yeah, there's a few studies been done on general back pain, chronic back pain and neck pain, where they targeted the ligamentous tissue and muscular tissue surrounding the spine, like the deep paraspinal muscles. And they showed quite good results compared to the control groups. They're limited, these studies. We just had a study out with actually using focus shock waves on chronic facet joint pain, which showed good results too. We also seen some experimental studies on spinal cord lesions, where we actually tried to target the nervous tissues, spinal tissues, and we've seen regeneration at some degree of the nervous tissue surrounding that too. But it's very experimental. I'm doing a pilot project now on chronic disc prolapse lesions, HIS lesions, and other structural changes in the discus, where we can actually target these tissues here again. And we've been doing MRI scans before, and when we would like to evaluate them like 6 months afterwards, we use a lower dose, so it's not painful, so it's not detrimental to the spinal tissues. And so far, we have had quite good clinical results by actually utilizing that. You have to do your diagnostic work properly and rule out any other lesions to the bony structures and the nervous structures too here. So, but we chose these candidates which weren't surgical candidates and haven't responded to conservative care. And it seems that it can actually cause some effect on these patients.
And the last question, which is off the clinical topic, which we've had asked on here, is for somebody who's opened up a new clinic or opening a new clinic and are looking at the differences between radial and focus. It's a question that comes up all the time as to which one is best to be investing in if you're going to do Shockwave.
It depends on which conditions you want to treat. If you want to expand to treating nearly all musculoskeletal conditions, and not only superficial but deeper ones, I would definitely recommend you buy a focus device. A radial device will work really good with superficial structures by pain modulating them. But if you want to go into like see intra-articular lesions, cartilage lesions, meniscus lesions, labrum lesions, and things like that, capsular lesions, I would definitely recommend that you invest in a focus device. Also, due to the diagnostic abilities by using that device, it will really fulfill you as a clinician because it will open your eyes to a lot of other structures and how they work together. So I can only recommend that. So it's a question of temper and what you want to achieve. We have both devices in our clinic. We primarily use the radial devices for soft tissue work and desensitizing bony structures, where if we want to regenerate and really pain modulate, we use the focus devices. Sometimes we use them together in the same treatment, depending on what we found by the what structures were actually compromised. And again, it shouldn't stand alone, the focus device. You have to take all the other tools into consideration when you treat these patients. But definitely, you get a much more higher energy output, so you can actually potentially cure much more resistant injuries by using the focus shockwaves.
Any questions in the room? No more questions? Brilliant.
Yeah, then I would like to thank you for the opportunities to have this short workshop, and I hope that you get got some clinical value out of it that you can use tomorrow at work. Thank you for your attention.
Huge thank you to Anders, traveling all the way as well. Thanks for everyone attending in person. Really appreciate that, and thank you for everyone attending online. Hope you've had an informative evening. We're going to end the live stream now, and the recording should be with us in 2 to 3 days.